So the IWK Health Center is the tertiary care center, so that's intensive care for mothers and newborns for all of Nova Scotia. In addition, we provide tertiary level care for premature infants and surgical infants from PEI. So any baby less than 32 weeks from PEI would come here for the initial part of their care. And we provide services to New Brunswick for infants with cardiac and surgical issues, or for babies who have complex pediatric conditions that require the access to a variety of pediatric subspecialists. In addition, we are the hospital situated here in Halifax, and we provide delivery services for well newborns and for healthy moms with pregnancy for about 50% of the deliveries in the province a year. So we do high-level care, intensive care, we do primary care, and in the middle there's something called secondary level care, which is the care of the baby who or mom who are a little more complicated than usual, but not critically ill. And so we provide the bulk of that for Nova Scotia, with the exception of one of our centers, which is in Cape Breton, that has that service available. Moms who have early onset of labor, for example, where you would expect the baby perhaps is going to be preterm, will often come here for their care, not because they can't take care of the mom in the outside center, but because the care for the baby is better done here. In that case, if a mom came in, say at 28 weeks, 40 weeks being a normal length of a pregnancy, in labor, that mom in Yarmouth, for example, if she was in labor, would be sent here. If she settled down and got a little further along and things looked good, she'd go back to Yarmouth and hopefully deliver when she was closer to term. So the usual rule of thumb is that if either part of that partnership, the mummy and the fetus, are anticipated to have requirement for higher level of care than can be done in the regional center, the mom and baby, or mom and fetus, will be here. And when that goes away, or that risk goes away, then we, as much as possible, try to get the mom and baby back to their community and their own care providers. So taking PEI is actually reasonably straightforward. We have a great working relationship. There are two centers in PEI that deliver babies, one in Charlottetown and one in Summerside. In both of the centers, they have pediatricians and obstetricians. And so often the sending factor in the patients that I see is the fact that the baby is anticipated to be more preterm, or the baby's been born and is preterm. And so the facilities to take care of babies less than 32 weeks require that you have ongoing ventilation. We have special kinds of nutrition and IV access, which is a difficult thing to maintain over a number of days. So although the baby is born, it can be born there and can have the initial part of the care, then doing the ongoing care for babies that small is not something they have the ongoing resources for. And that's from equipment to staff to nursing to actually just an intensive care unit, although there is a small level 2 unit in PEI, which does very well with the babies there. So the goal then would be to get the mommy over here if you're going to have an early baby, have the baby born here, stabilize those services that you require for the baby that are only here. Once those aren't required anymore, getting that baby back home to their home hospital. And sometimes we'll actually get the babies from Summerside who are born back to Charlottetown, because Charlottetown has a little bit more hospital resource at the time to take care of them. Our ultimate goal is to get babies back to whence they came from. New Brunswick is a little bit different. In New Brunswick, they have 3 neonatal intensive care units with neonatologists, which are specially trained pediatricians. There's no neonatologist in PEI. There's one soon to be, no, there's 2 now. 2 now in Moncton. There's 2 now in Fredericton, and there are 2 in St. John. So from the baby point of view, there is a neonatal intensive care unit in all 3 of those centers. Smaller than the IWK, because the birth cohort would be about the same in New Brunswick, a little less than Nova Scotia. Also in those 3 centers, they have not only obstetricians, but they have something called maternal fetal medicine specialists, which are the high-risk obstetricians. So that means that the level of acuity, or the level of illness in both mommy and baby that can be cared for in those 3 centers is higher than when you have general obstetricians and general pediatricians. So from New Brunswick, the patients that we would see tend to be those who need other pediatric subspecialties. So those who would need urgent genetic consultation, cardiology consultation, nephrology consultation, where those services and those subspecialists are only here in Halifax for Maritimes. So most of the preterm population is taken care of in New Brunswick for New Brunswick babies, unless they require surgery or one of the specialties. Now, occasionally you'll have a preterm. Most of the preterm babies that come from New Brunswick to us come because they need a cardiac surgery done, or they need some intervention from our ophthalmologist because of some of the complications that are fairly common in the preterm population. But Cape Breton is a little different than the other parts of Nova Scotia because they do have a neonatal intensive care unit in Cape Breton, and they have one neonatologist who works in Cape Breton, and several other pediatricians, of course, who work and are fairly comfortable working in newborn medicine, particularly with having the backup of a neonatologist there. So the preterm babies that are born in Cape Breton are much more akin to the babies that are born in New Brunswick. If they have uncomplicated courses for their preterm delivery, we don't necessarily see them here in Halifax. They would come to Halifax for similar reasons that they would come from New Brunswick. The only difficulty is when you're a N of 1 neonatologist, you can't work 24/7, 365 days a year. So there have been some times when the preterm population, the moms who are expecting preterm delivery, or the babies who get born preterm, if the neonatologist is away for a period of time, do end up coming to Halifax. And sometimes the moms are here and having shared care, because there's, remember I said it's a dyad, so there is not a fetal maternal medicine specialist in Cape Breton. So for those moms who have significant maternal conditions like hypertension or diabetes, or those complicated multiple pregnancies, or identified issues with the fetus beforehand, those moms often will have their care here with the plan that they would come and deliver here. The bigger term population that we see that inhabits NICU, and a small part of it which is shared with our pediatric intensive care folk, are the babies who have surgical conditions that we know about, babies who have chromosomal or genetic abnormalities that we know about that require further investigation once they come, and the babies who have the significant cardiac disease. The cardiac ones are the particular shared population. We share the care with the obstetricians and high-risk folks beforehand, and we share the care with the pediatric intensivists, the cardiologists, cardiac surgeons afterhand. So they're a group that see a great deal of the service here at the IWK. And that group, we would provide the care for anybody in the Maritimes with that issue. And to a certain extent for some of the infants from Newfoundland. So we have what's called a maritime mandate, which is 3 maritime provinces. But there are certain services in Newfoundland which we're now seeing that they don't have all of the resource for some of their subpopulations that we have the subspecialists for. So the cardiac surgery patients are some of those, some of the infants with renal problems. So infants who need dialysis, for example. There's not very many of them, but that's a service that we have here for the Maritimes, but we also extend to Newfoundland as well.